Everyone. Hello, everyone. Thank you for coming in. We're just letting people into the waiting room, so we'll be a couple of minutes. Okay, it's 12:03, and I think we've admitted most of the people in the waiting room. Good afternoon, everyone. My name is Anna Wallach. I'm a family physician, and I'm going to be the moderator today. Welcome to the first session of the BC ECHO Project ECHO for post-COVID-19 recovery. We're very excited. This is our first session, and it's talking about the post-COVID-19 perspectives for primary care. So for those who are unaware, the Project ECHO project is a virtual learning community of specialists and community healthcare providers, and we're using a combination of didactic and case-based learning to help improve care for patients recovering, in this case, from symptoms post-COVID-19. So just some housekeeping announcements. First of all, this is an accredited program, and you'll be receiving one main pro or one MOOC credit. And certificates will be sent out to you. To track attendance, we are asking everybody to please put their first name and their last name and their email addresses in the chat function so that we know who's here, and we'll be able to issue your certificates. With question and answers, we want this to be as participatory as possible. So just use the raise hand function on your Zoom screen, and then we can call on you to answer questions. Dr. Jansen, our presenter, has said she's happy to answer questions throughout her presentation, so we don't need to wait until the end of the presentation for that. And without further ado, let me introduce our speaker today. Our speaker is Dr. Renee Jansen. She's a general internist who practices at St. Paul's Hospital and BC Women's Hospital. She has her interests in addiction medicine, central sensitization syndromes, and medical education. She's an attending physician on both the clinical teaching unit as well as the addiction medicine consult team at St. Paul's. She provides care for patients with fibromyalgia, chronic fatigue syndrome, and other similar disorders at the complex chronic disease program at BC Women's. And in the past year, she has provided care for patients at the post-COVID recovery clinic at St. Paul's Hospital. So take it away, Dr. Jansen.
Thank you. Thank you all for joining today. Yeah, so this is, I have probably about, just so you can anticipate, about 30 or 35 slides. I'll probably talk for 30 or 35 minutes, something like that. It's a little bit atypical in that usually during for ECHO, we have someone bring a case, and today I'm the one presenting a case. But I'm also happy to answer questions or have a discussion as I go. So, you don't need to wait to the end if you have a burning question. And I'm happy to kind of talk as it comes up. So let's get started. So firstly, I have no disclosures or conflicts of interest. As Anna mentioned, one of the reasons I'm talking to you today is that I have some experience in looking after patients in the post-COVID-19 recovery clinic at St. Paul's Hospital. And I also have been working at BC Women's Hospital for some time, looking after patients with chronic fatigue syndrome and other disorders. And that's partly why I had some interest in doing work in patients in the post-COVID-19 syndromes as well. So just objectives today. So firstly, my hope is that you'll have a bit of an appreciation for what our approach is to evaluation of patients with prolonged symptoms following SARS-CoV-2 infection. Identify those patients that you think warrant further evaluation for their symptoms. And we'll talk about an approach to investigation of symptoms. And my goal today is not that that we have a very prescriptive set of rules or protocols for doing this, but more that you get an appreciation for our approach to that, and what is enough investigation and what would be maybe too much investigation. Identify those patients who require referral to subspecialty. And I just wanted to point out that I won't be talking about treatment today. There's lots of other COVID sessions coming up on diagnosis and treatment, and today is just sort of the first overview. And then I have a case. And if you have cases today and we have some time, I'm happy to hear some of those and talk about those as well. So, in putting together this talk, I had some chance to kind of reflect on our medical journey really in the last year and a half. And, early on, of course, we were very focused on learning about what is this virus? How does it work? How does it infect people? How is it transmitted? And we're focused on how to quickly and rapidly identify what are some of the treatment targets, all those kinds of things. So early on, that's what we were very focused on. And, initially we started to become familiar with the natural history of acute COVID-19. But, to our surprise, perhaps, it turned out that a number of patients didn't get better at the expected time course of a viral infection. And, a good proportion of patients had persistent symptoms or even new symptoms that developed weeks after the virus was presumably long gone. And so this sort of pattern of post-COVID symptoms started to emerge across the world, and people started to characterize it and gather more information and start to give it names. So, here's another publication sort of earlier last year, starting to track the constellation of symptoms in the acute phase, but also those symptoms that we started to see in the post-COVID-19 phase. And sometimes they were the same, but the distribution was different. So the interesting thing about this is that, post-COVID-19 is actually not a new phenomenon. Post-infectious fatigue syndromes following viruses, this is not a new thing. And I'm sure, some of you are aware that there is a post-Ebola syndrome, which obviously is less common, but has been characterized. Certainly people after contracting infectious mononucleosis, some people were very debilitated for very prolonged periods of time. And in fact, some people never did recover. There's also, of course, SARS. This kind of syndromes were characterized in patients following SARS, as well as the Middle East respiratory syndrome as well. So it's interesting, this seems to be a phenomenon with particular kinds of viruses, and I'm not sure we're entirely certain as to why still, despite all the research. The trouble, of course, with SARS-CoV-2 causing COVID-19, the trouble is, of course, it's a very effective virus in that it affects it causes mild symptoms in most patients, and therefore is very readily transmitted because most people do okay. And of course, so, a large number of people have developed COVID-19 in contrast to things like Ebola, of course. So this has led to these kinds of inflammatory headlines that, we're anticipating, given how many people worldwide have been infected, a massive impact in terms of people with prolonged symptoms, some of whom have never been able to go back to work. So now we're starting to realize that the medical system not only needs to deal with the acute COVID pandemic, but also the impact of patients who are sick for a very long time. So this number I chose because really we don't actually know what the number is, and part of the problem is it depends on your definition, right, of long COVID. And so the numbers in the literature is a very wide range. And I think in our clinic at St. Paul's, we feel the number is lower than 10%, thankfully. But and it depends where you draw the line in terms of persistent symptoms after 4 weeks. Of course, fewer patients have persistent symptoms at 12 weeks compared to 4 weeks. But regardless, if we say that 10% of people are going to develop persistent symptoms after 4 weeks, that turns out to be a lot of people. I pulled some numbers from BC from last Friday, and so far we've had about 148,000 cases, which means that upwards of 14,800 people are going to have some form of long COVID or persistent symptoms. So this is obviously something that all of us are going to have to learn how to manage. And of course, most of that's going to fall to primary care, hence today's session. So firstly, just some definitions. A number of different names have emerged, and some of these are names suggested that have come from patient populations like long COVID and long haul COVID. Others have been suggested as a more formal name for the purposes, for example, of research, to ensure that you have a definition, a case definition for the purposes of research. But this adds to the confusion. There's so many names, and and some of us wonder even if the patient has persistent symptoms of fatigue and post-exertional malaise and brain fog, et cetera, for longer than 6 months, do we start calling it myalgic encephalomyelitis chronic fatigue syndrome? So yeah, what to call it is part of the problem. And then the other problem is that long COVID is so variable in its presentation. Every time I do clinic, I feel like I'm seeing a patient with a new symptom I maybe haven't encountered before, or a new variant of a symptom. So it may be some people who develop new severe headaches who never had headaches before, people who develop new severe anxiety and depression who historically never had mood disorder, or perhaps by long COVID, we are referring to patients who develop pulmonary fibrosis. So the term also has no clear definition, and everyone means sort of something different. So if you're feeling confused at all about long COVID, that's quite reasonable. And I'd say we all kind of share that. And part of it is just the lack of clear definitions and the variability of presentation. So let's find some definitions from official organizations. So the CDC defines acute COVID as anything up to 4 weeks, and then anything after that is considered to be post-COVID conditions. So, obviously you're going to have a higher percentage of patients with post-COVID conditions if your cutoff is at 4 weeks, and at 12 weeks, thankfully, most people, or a lot of people, have improved to the point where they no longer can be considered to have persistent symptoms. So let's talk about presentation. So, typically, there have been a number of different survey studies and recent publications. Another recent white paper was recently published, but these are the most common symptoms that we're seeing. So fatigue is obviously kind of tops the list, brain fog, dyspnea, out of keeping with exertion, typically, persistent cough, painful joints, painful muscles, chest pain, often non-cardiac in type or in character, depression, anxiety, and other mood disorders. We're seeing quite a lot of new headache syndromes. Also, I'm seeing a lot of that. people who have subjective fever, and then palpitations, and then, other kinds of dysautonomia. So, dizziness on standing, orthostasis, tachycardia with minimal exertion, or tachycardia with changes in position. We're seeing a lot of that as well. And then post-exertional malaise, where people feel a little bit better one day, push themselves, and then the next day are pushed 2 steps backwards. Now, there's a much wider range of symptoms and signs that we're seeing, but these are the most common. So these are the things that you should be asking for when you're assessing your patients. So a lot of people want to know, so can we predict who's going to get long COVID? And the answer is, well, no, it's actually quite hard to predict, but there are certain factors that seem to put people at higher risk, and one of them is sex. So if you are female, you are more likely to have long COVID. Interestingly, we see the same numbers with patients with, myalgic encephalomyelitis and chronic fatigue syndrome. Maybe not the same numbers, but it's certainly more common again in women. And age, it's people, it's the taxpayer cohort. So it's people sort of between 35 and 49 years of age who are most likely to develop long COVID. And then in terms of numbers, so patients with severe COVID, statistically speaking, are still the most likely to develop long COVID. But I think the surprising thing is that there's a quite large percentage of people who had only mild symptoms and managed at home, or even more surprising, people who were entirely asymptomatic during their acute infection who developed long COVID. And that's one of the mysteries of this. So let's move on to a case. So this is one of the cases that we've seen here at St. Paul's Hospital, and I've changed the information just a little bit for the purposes of privacy, but it's fairly close to the actual case. So this is a 47-year-old lady with a past medical history only notable for hypothyroid. In no particular order, she historically was an ultramarathon runner, and then she's also a mother to several young children, and she was working as a nurse at the time of contracting the virus. She got the virus fairly early on in the pandemic, so last spring in 2020. And initially her symptoms were quite mild, and she managed home. And then slowly she, actually fairly quickly, recovered to the point where she was able to exercise and run again. And then she had a fairly major setback in terms of symptoms. She started developing chest pain and shortness of breath. And she presented to a local acute care facility, and they did some initial investigations. And her troponin was positive in the emergency room. And so out of an abundance of caution, and given that she was a young person, they decided to admit and for further workup. And then she had a number of investigations. So she had an echocardiogram, which was unremarkable. She had a coronary CT angiogram just to rule out any ischemic heart disease causing her chest pain and elevated troponin. And that was unremarkable. Essentially, she had no significant coronary artery disease. She also had a cardiac MRI because they were considering the possibility of myocarditis. And the MRI had some subtle abnormalities, but there was nothing really clearly abnormal. But there certainly wasn't any evidence of myocarditis per se, which is the thing that they were worried about. And she also had a CT chest, a dedicated high-resolution CT chest as well, which showed some subtle interlobular septae, and no one was really quite sure what to make of that. And it didn't seem to be sufficient to explain her symptoms. So eventually she was discharged. And ultimately they gave her a working diagnosis of probable myocarditis, although I have to say really the only thing she had was positive troponin. So even that's unclear. So she went back home again, and following this admission, she really didn't recover. She had ongoing pathological fatigue. She tried to go back to work. She was unable to. She had significant post-exertional malaise. She had dyspnea out of keeping with her exertion, and certainly compared to her previous level of activity as an ultramarathon runner, she was really hardly even able to go for walks. Her sleep was non-refreshing. She had new anxiety. She had quite significant brain fog. She had quite significant hair loss, and this was particularly worrisome to her. And as I said, she was unable to return to work due to her symptoms. And she tried a number of times and being at work and wearing a mask in a fairly dynamic environment, she was just not able to tolerate it. So this was early on. I hear a voice. This was early on in the pandemic and in our clinic at St. Paul's, and so all of us were a little bit more likely to do extensive investigations, and I've seen over time we've gotten more comfortable with the patient population, and so I'm presenting this workup not as what we should do, but what we did at the time, because this is a young person who was previously very high functioning, and we just wanted to make sure we weren't missing anything. So she had a referral to respirology for her shortness of breath. She had full pulmonary function testing, which was all normal. She had measurement of maximal inspiratory pressures and maximal expiratory pressures, looking for perhaps a muscle weakness that might explain her sense of dyspnea, and that was normal as well. She had a formal cardiopulmonary exercise test, which showed normal capacity, although they pointed out in the report that it's all relative, and for someone who perhaps was previously an ultramarathon runner, that the current normal might, for her, be a significant reduction. And then they repeated the CT chest again. This was several months later after her summer admission, which showed maybe some improvement in those subtle interlobular changes, but essentially nothing that would explain her symptoms or that would account for her symptoms. So really what she was left with is no explanation for why she was so short of breath. So one of her symptoms, as I mentioned, was a new anxiety. And so we referred to our psychiatry colleagues here at the COVID clinic, and she was started on escitalopram, and she, I think, found it to be somewhat helpful. And then she also started counseling, which also was sort of providing her with some benefit. And then for the hair loss, we referred her to dermatology. Again, this was early on. I probably wouldn't make this referral anymore because we see so much hair loss now in long COVID that I've become comfortable at just reassuring people that this is something we commonly see. But this was, like I say, one of our earlier patients. So dermatology saw and felt it was most likely to be telogen effluvium, which is a syndrome that we see following intense stress or trauma or severe illness. Similar a little bit to pregnancy hair loss, but different. But that's also a telogen effluvium syndrome as well. And she was reassured that she would probably have, her hair loss would eventually settle and that she would eventually regrow and that she could try topical minoxidil. However, in having seen her again, she's, her ponytail went to about a quarter of its previous size. So it was quite dramatic, and she was very upset about it and self-conscious, and she would often wear a head covering. So this was actually quite bothersome to her. So just to summarize where she's at, most recently when I saw her a few months ago, she's still unable to work. She really hasn't made a lot of progress in terms of her fatigue. She continues to have shortness of breath with minimal exertion. She continues to have post-exertional malaise and sleep dysfunction. Her mood disorder is still present. And she still has, pathological fatigue and brain fog, and she doesn't really feel like she's gotten any better. I should say this is not a typical case, by the way. This is a complex case, both in that there were some objective findings of abnormal tests, and also she just did not, most of our patients in our clinic, most of them are improving and generally are doing well. And when we see them in the interim, they generally are doing better than the last time we saw them. So this is more of an atypical case. Just wanted to point that out. So I wanted to talk a little bit about this concept of,
Before we continue, Katie McAleer, I'm going to unmute you or ask you to unmute. You have her hands raised for a question.
Yeah, hi.
Hi, I wondered also, is it typical or atypical that she had that time of improvement where she got back to her normal activities and then decompensated again?
Yeah, good question. So often people during their acute symptoms have a particular subset of symptoms, and often, well, I would say some of them do start to feel better, or those particular, say, respiratory symptoms resolve, and they maybe start feeling a little bit better. And then often there's this sort of second wave of new symptoms that shows up. And then they start getting worse again. Although some people just never bounce back up again. So I would say I've seen both. Yeah. In her case, it is, I would say it's not atypical. Her clinical course is not atypical. Yeah, so medically unexplained symptoms. So, this is commonly what we're seeing in this patient population, where people have persistent symptoms, and yet we do investigations, and this is not what we're telling people, but these are the kinds of things that people think, right? So everything has come back normal. We're not telling people that there's nothing wrong with them, but this is sometimes what they think, or the messaging that they're getting elsewhere sometimes, that there's no explanation for their symptoms, and so they just need to kind of keep pushing through and they'll get better. Maybe start meditating or something like that, right? So these are sometimes the kind of the messaging that patients hear. And so I just offer a definition firstly for medically unexplained symptoms. So persistent symptoms and loss of function despite normal labs, imaging, ECG, et cetera, and other objective measures of organ function. I just want to point out, and I feel like most of you, I'm sure you're well aware of this, but this is not psychosomatic. These are not somatoform disorders. These are unfortunately, this just probably reflects the fact that we have inadequate tools to capture the pathology that they are experiencing. Most people, as I'm sure you're well aware, are very distressed that they're not getting better. They really want to be back at work. They're bored of being home. They're bored of trying to, they're frustrated that they try to go for a walk one day and they pay for it the next day. So this is definitely not a somatoform disorder that we're dealing with here. So I guess the question then comes is, what is the cause of long COVID? And as you can see, there's a lot of question marks here. So in other words, we don't really know. There's a number of theories or hypotheses, I should say. So, certainly there's imaging studies that have showed evidence of multi-organ dysfunction, some of the research studies, with the special tools. And so perhaps it's just organ damage, direct organ damage, perhaps complications from this sort of acute hyperinflammatory state, perhaps the presence of low level of viral activity or viral, antigens, perhaps in some people inadequate antibody response, or conversely, too much immune response causing dysfunction. And then, people, of course, some people have comorbidities, and perhaps their comorbidities were worsened. And then, especially with things like mood disorders, there's, extrinsic factors to consider, like being in lockdown or being in isolation, or just the change of our pattern of life obviously have an impact on people. So here's sort of my general overview of how we typically approach patients with persistent symptoms following SARS-CoV-2. So firstly, what you're doing is you're reviewing, a set of symptoms, and you're asking, and we have lists and of the more typical things we anticipate. And so we'll ask people specifically, and we have questionnaire studies. We'll ask them, and probe for specific symptoms. And then we'll focus in on those symptoms and investigate, depending on what the symptom is. It's just worth pointing out that exhaustive investigations are not required to rule out objective end organ disease. So not everybody needs, like for example, doing MIPS and MEPS, I would say that in that first patient, or that patient I mentioned, that would be, it may be that there is a patient where that seems like it's clinically indicated, but that is definitely not our general approach to dyspnea, for example. And then it's also important as you're investigating, especially if you're finding that everything's coming back normal or unremarkable, to validate and to point out that there's a disconnect between the patient's experience of how they're feeling and, the test results. And finally, for those patients who don't seem to be doing as well as you expect, or who have some red flag findings, or who have objective findings of end organ disease, then that would be the time to consider referral to a specialty. I think there's a hand.
Yes, there's a hand for Brian's iPad.
Hi. Well, anyway, so Dr. Jansen, you actually looked after me when I was on the internal medicine unit after my COVID infection.
Oh, I recognize your voice. Hello.
Yeah. I could. No, thank you very much for again doing this talk, and it's obviously of great personal interest as well. But there was just recently an article on the kind of the Canadian Physician for COVID Facebook group that was talking about actually quite a high incidence of suicides after in people with long COVID syndrome. I think what you spoke about validating the concerns is really, I think, the very powerful thing. I think it kind of addressed a lot about, oh no, everything's fine, so it's normal. That I think it's just such a hugely powerful thing. So really, I want to say thank you very much for addressing that. So.
Oh, I'm glad, and you have well, yeah, I guess that you have, yeah, I guess you would know. So thank you for sharing that, because I can't speak from personal experience, but yeah, and this, I mean, this is coming as well from my work with patients with myalgic encephalomyelitis, chronic fatigue syndrome, fibromyalgia, and those other disorders that similarly have like medically unexplained symptoms and a disconnect between how poorly people are doing in their labs. For example, often patients experience, I think frankly, just from probably in some cases, physicians just feeling like they don't, it's hard to know how to treat and counsel a patient when you don't really know what's wrong, or when you don't have anything to sink your teeth into in terms of treatment targets. So I think we feel inadequately prepared to work with patients who look fine on the outside. So yeah, I think just, yeah, exactly, the reminder to acknowledge how difficult it is for people, and to acknowledge that there is this disconnect, and that doesn't mean that their symptoms aren't real is important. So thank you for sharing that. Okay, so now this is not meant to be an exhaustive protocol list of what you should do. What I'm hoping that you get out of this is just some reassurance that your pragmatic approach to what you would normally do for these symptoms is totally reasonable. And so, for patients that we see at the post-COVID recovery clinic, for those patients who have been admitted to hospital, we tend to do a little bit more in-depth investigation, because on average, those patients are more likely to develop, long-term sequelae. So, but in general, if somebody comes in with a cough or shortness of breath, we're ordering pulmonary function testing, we're doing a CT chest, and some, in some cases, especially hospitalized patients, we're doing echocardiograms. We do a 6-minute walk test, which is, more of a functional kind of snapshot of how people are doing. If somebody's having palpitations, we'll order, say, a Holter or an electrocardiogram. If somebody has chest pain, again, an electrocardiogram. Depending on the patient, an exercise treadmill test might be a reasonable thing to do, and gives you some other information as well, like blood pressure response, and what's their exercise tolerance or METs achieved, for example, or a coronary CT angiogram in some patients if you're thinking ischemic heart disease, and that, if they're young enough. So orthostasis, very common symptom. So we're doing orthostatic vitals. We're screening for postural orthostatic tachycardia syndrome. So essentially, measuring heart rate lying and standing, usually first thing in the morning. And this is something patients can actually do at home and provide you with the information. We're not doing tilt-table testing for these patients, for example. And then for mood symptoms, this is just a little bit of like, I don't know what to do with these patients because I'm GIM. Family practice is obviously the majority of mental health is looked after by family practice in this province, right? So, and if you're comfortable and you have a patient, well, and has new mood symptoms, then I think our psychiatry colleagues typically are starting with SSRI. And I think there's an entire session from Dr. Miller, if I recall, coming up. So you'll certainly probably hear more about that. I think I see a hand.
I have a question from Dr. Chan. Could you please unmute yourself?
Hi, thank you, Dr. Jensen. I have patients who ask me whether the liver or liver enzymes could be affected. And some people who recovered asked me if I could follow their liver enzymes like a few months later. Is there a cost? Like, I mean, assuming these people are not super symptomatic, they're not having, you know, biliary colic or jaundice or anything like that.
Yeah, exactly. I think that's really reasonable. So we certainly see a lot of elevated liver enzymes in acute COVID, and occasionally we see elevated liver enzymes later on in the clinical course as well. So the usual approach of you know, considering a broad differential diagnosis, following the liver enzymes over time. If it looks like it's a cholestatic pattern, then you'd consider ultrasound, you know, that kind of general approach. I would say there isn't anything special or specific that we do for patients with post-COVID with elevated liver enzymes that I can think of. I think just a general approach is totally reasonable. And like you say, many people just have asymptomatic elevated liver enzymes, and I will typically follow those over time. Make sure there's not a medication or something else that could be contributing. Yeah.
We have a question from Dr. Dosa. Could you please unmute?
Looks like she is.
Karine?
I'm having trouble with my device. Can you hear me now?
Yeah.
Yes, we can.
Okay, sorry about that. Thank you, Anna. And thank you so much, Dr. Jensen. This is so very helpful. Just to follow up on that last question, which I thought was excellent, because part of the issue as family doctors we have is sometimes wondering about over-investigating, you know, and sort of the choosing wisely campaign, like, you know, what are the values actually going to tell us? Are they going to change our management? You know, what is too much? So in a completely asymptomatic patient, to follow their liver enzymes over time, I guess I just worry that, you know, does it lead to sort of further testing that ends up being contributory to management, or does it lead down red herring pathways? Or at what point do you decide that, okay, we need to focus on symptom management and symptom relief rather than, and you've kind of alluded to this in your previous slide as well, rather than chasing down further investigations?
Yeah, good question. I mean, I have a few thoughts about that, I guess. You know, if somebody, I guess it depends on how elevated they are, firstly, like, and did they ever previously have elevated liver enzymes? If they've always had mildly elevated liver enzymes, well, you know, they probably have NASH or something, or, you know, or NAFLD, or, you know, some kind of, maybe they have fatty liver disease. And that's actually worth chasing down, because, you know, the impact of that can be considerable, of course, COVID aside. So, and I'm kind of stating the obvious there. Also, it depends on how elevated, like if somebody has liver enzymes that are hundreds or thousands, well, of course, you're going to feel like you need to investigate that, and that's a reasonable thing to do. But if you have that persistent grumbling elevated liver enzymes and they're asymptomatic, or you have a known diagnosis previously of fatty liver disease, then yeah, I don't know that there's necessarily a lot of value to be following that regularly and, you know, doing them just once in a while. It's just whatever kind of makes sense to you, I think, clinically. And I think your general gut sense as to what would be a reasonable approach will be totally appropriate. But you're right. I mean, we don't pan scan people for a reason either, right? So yeah, it's choosing wisely is worth considering. Focused investigations, looking for something specific, and then moving on if you've ruled out the things that you're worried about. Yeah.
Okay, that makes sense. Thank you so much.
Yeah, and there's a couple of questions in the chat. The first one is from Leslie Wood, a question regarding the specific management of the orthostatic symptoms, as they've heard that concern in multiple patients. But I think that it's out of scope of our talk this morning.
It is, but I will say that there are some really great guidelines off the top of my head, some great guidelines for POTS, if you think that's what's going on the BC Women's Hospital CCDP website. The Complex Chronic Disease Program. Yeah, so I won't get into that because there's an entire talk on dysautonomia with Dr. Jill Calder, which I'm really looking forward to. But there are some protocols out there. And there's actually an entire, what's it called? Canadian Cardiovascular Society guidelines that came out on POTS just last year. So if you want some nighttime reading. There's a 50-page document there for you that will tell you all you need to know and more.
And there was another question, which actually was my question as well. So thank you, Carolyn Young. She was asking if there was any change that's been noticed in post-COVID symptoms after they've gotten their COVID vaccinations. I know anecdotally I've read as well, and I've had one patient report that all of a sudden they've gotten better. So is it an anecdote versus a trend that we're actually seeing?
Yeah, that's, I mean, that question comes up, and I've had patients who got worse. I've had patients who got better, and I've had patients who noticed no difference. I think there was a publication a little while back. I think it was a British publication, and they looked at this, and I don't actually recall the exact numbers, but my overall memory of it, that it didn't have a lot of evidence that there's a major impact for most people, and that like most people are getting better. But yes, there are patient reports on blogs and website and groups that some people are getting better after the vaccine. I had a patient recently who claims that the heat wave was really the thing that allowed her to turn the corner, and that where she got way better after the heat wave. And that to me is a little bit surprising, but you know, correlation, causation, who knows? Yeah. Okay. All right, so approach to fatigue. So like working up fatigue is kind of it's a big one, right? It's such a non-specific symptom, and it could be something really serious, or it could just be that somebody has unrealistic expectations for how much they can do in a day. And really it's taking the patient history, knowing the patient beforehand, of course, and then this is our just general approach to labs for workup of fatigue. And as you can see here, there's nothing that's particularly shocking or surprising that you wouldn't already be doing. So, you know, that's, you know, kind of our basic approach. And then also just a historical feature. So post-exertional malaise is quite specific in its character. So, you know, asking the patient, when do you have fatigue, and getting a sense of how it relates to their activity level. And sometimes patients aren't actually aware of the connection between the two. So part of it is just getting a really good history, I would say. And I'm not going to really address the last point other than to say that, you know, early on when I was seeing these patients in my mind, you know, if they had these symptoms that met criteria for ME/CFS, that I would be assigning this label and for patients in the post-COVID setting. But I've sort of changed my mind about that. And I've done some reading of a number of other physician specialists around the world, and there's a lot of different opinions on that. And so my sense is actually that that they are different. And like most patients who have persistent symptoms at 6 months following COVID, a lot of them still are getting better. And I anticipate will continue to get better, which is obviously not typical for someone with a diagnosis of ME/CFS. So I'm holding off on assigning that label, but I think I have another slide about that briefly, but that's my personal opinion. This is not like backed up with evidence or guidelines. I think there's still a lot of uncertainty around that question. But it's worth thinking about, because you obviously you treat them differently a little bit as well, or at least you anticipate the time course to be different. So just finally, just to talk about when to refer to subspecialty. And the answer is, well, that just depends really, I guess. It depends on your comfort. Like if you've seen a lot of patients, eventually you'll start to get a sense as to, well, this is probably typical and I'm comfortable managing this. And that'll probably change over time with your experience with the patient population. And then of course, depending where you're working, who you have access to and what way you have access will be different than if you're working in a large urban center. In general, I would say if you have a patient who has normal investigations and the symptoms you feel are typical for what you would anticipate for someone with long COVID, and in general, they seem to be improving, then it's totally reasonable that person does not need a referral to subspecialty. And I'm sure you know that, but I'm just basically reemphasizing what you're probably already thinking. In general, so at St. Paul's in the post-COVID recovery clinic, we have more readily accessible access to subspecialty. And some of the subspecialty there, you know, it's part of the clinic or sort of all tied together. So when we typically refer, if we have objective findings of organ dysfunction, so if somebody has new pulmonary fibrosis or we think they have an organizing pneumonia, then we definitely refer those to respirology. We have seen a lot of exanthems, a lot of interesting rashes. A lot of those we refer to dermatology, and some of them need treatment. If they develop thrombosis, we have a thrombosis service that we would typically refer to. We see a lot of, I'm just giving, these are some sort of random examples, it's not an exhaustive list, but we see a lot of patients with voice dysfunction, for example. So I typically am referring some of those to the Pacific Voice Clinic to see ENT. So these are, I'm just kind of give you some examples of when we refer on. And then finally, the point about, severe fatigue that's persisting and you're starting to think about chronic fatigue syndrome. Is this someone's going to end up with permanent disability, fatigue, post-exertional malaise? If people after 6 to 9 months have plateaued or are going backwards or not getting better despite resting and not working, so like in other words, they're not pushing themselves to being worse, they're actually resting and doing the right thing, and they're still not getting better, I do worry about those patients, and we certainly see some of those here. And I am suggesting a referral to the complex chronic disease program at BC Women's Hospital for those patients. We don't have any specific guidelines as to when to refer, but that's kind of what I've been doing. As some of you probably know, the wait list there is over 2 years. So the other reason I'm sort of referring, even if I'm uncertain, is partly just because I know they're going to have to wait a long time if they do end up needing it. So partly it's logistic, unfortunately. And now, yes, don't forget about the race line. So, Monday to Friday, there is a specific physician on for COVID-19. So if you have questions about investigations or what to do next, or should you refer or not refer, we're just a phone call away. And I just wanted to bring your attention to these points from the CDC, which I thought kind of re-emphasized some of the things I'm saying and had some new ideas as well. So firstly, this whole naming problem, it's an umbrella term and different people mean different things. So you need to ask more questions about what is the patient actually experiencing, because long COVID means so many things to so many different people. And then in terms of your sense of how someone's doing, objective lab imaging does not give you enough of a picture. You obviously need to be assessing them as well. And again, re-emphasizing this idea that if everything's normal, it does not invalidate their symptoms. In terms of diagnosis and treatment, we focus in on specific symptoms, and there's future sessions on that. And then just a moment of humility, like our understanding of long COVID or post-COVID conditions is really very incomplete. It's actually amazing how far out we are and how many people around the world are working on all of this, how little we still know, or there's so many unanswered questions. It's really humbling. Okay, so that's just the same slide again. Finally, I just wanted to share some of the resources that I used and that I have been using. The CDC actually has a fairly nice website on post-COVID conditions. I haven't chosen this one because it's the best. It's just one that I've been encountering more and I've used more myself. I haven't done an extensive, look at all of the websites, but I thought this one was pretty good. And then we also have our own. It's housed under the PHSA website. So we have some videos, some patient-centered information, as well as care provider-centered information. So that's a good place to start your searches for looking to support your patients. Okay, so I think that's all I had. Does anyone have any other issues for discussion or questions, or perhaps we have time for a case even if someone has one?
There's a question here in the chat from Dr. Sally Law asking if there was any indication from WorkSafe regarding coverage for disability from long COVID for patients who've contracted COVID in their workplace.
Oh yeah, those patients should absolutely seek WorkSafe BC claim. And they, often are approved if there's any evidence that they might have contracted. There was an exposure in the workplace. Usually that's enough for them to be approved. And then they have access to physio, occupational therapy, and a back to work plan and graduated return to work plan. So yes, absolutely, WorkSafe BC. If there's any possibility that it could have occurred at work, then that's worth pursuing, absolutely.
Dr. Chan is asking, has anyone else noticed an increase in postmenopausal vaginal spotting after acute COVID? And some 40 to 50-year-old patients even tell her that they got spotting after the vaccine.
Wow, I have to say I have not encountered that, but I'll throw this open to the group. Has anybody else seen that? Because that is not something I've encountered.
Personally, I've seen a not postmenopausal, but a perimenopausal patient tell me that their periods got heavier in like the 6 months following the diagnosis.
I'm obviously not asking the right questions.
Brian has his hands raised, so please unmute yourself.
Yeah, so I'm actually an OBGYN. There's definitely well-documented side effects of menstrual disturbance after vaccine. And it actually makes a lot of sense that after COVID infection itself, you can have menstrual disturbance as well, just because the endometrium actually has a lot of immune kind of mediators and so on in the system. But one point is that, unfortunately, I think as primary care physicians, we still have to treat postmenopausal bleeding still like postmenopausal bleeding. I think the appropriate investigation is at least getting ultrasounds for endometrial thickness would be the very least to do. But in perimenopausal patients, there's not really any point. I don't find there's much point in doing that. But I think if you can do endometrial biopsy, that would be very appropriate. And I know all of us gynaes would be totally happy to do that with the referral. So just my 2 cents.
Thank you.
There's a comment here from Relitsa Spasova asking about trends in systemic labs that have been followed for post-COVID, specifically mitochondrial function. And
are you wondering if there's any testing for mitochondrial dysfunction? Is that?
I think if Dr. Spasova could unmute themselves and ask the question.
Yeah, so it's, sorry, my question was more about specific supplementation that would be recommended if there are labs that have been followed or trends that we've noticed that, you know, specific supplementation could help if there's certain trends that we know of.
I mean, I think we don't really have any great readily available investigations that have direct evidence of mitochondrial dysfunction. So that's partly the problem. I mean, I know certainly with the ME/CFS population and similar disorders, so one of the hypotheses for pathophysiology is that there's mitochondrial dysfunction, and there's some empiric evidence for that. And in those patient populations, we will trial mitochondrial support supplementation with variable success. But you know, it certainly isn't mainstream. There's not a lot of evidence for that, that's for sure.
Okay.
I actually have a question, and this is something that I know a lot of my fellow family medicine colleagues have encountered. The concern is certainly at the beginning of this all, when testing was limited, we had a lot of patients who may or may not have had acute COVID, but didn't qualify for testing. And now they're presenting with symptoms that remind us of long COVID, but they can't get that diagnosis, or we can't get them referred. And what I mean, we're managing them as if we would be managing anything else that comes with these symptoms. But I think a lot of it is they're looking for reassurance or a name to things. And do you have a particular pearl of wisdom that you could help us just to reassure them?
It's a tough one. It's almost like, it's like adding insult to injury, right? Like not only are they injured to the point that they are behaving like someone with severe long COVID, but they don't even have the benefit of the label. I think those patients really struggle in particular. So, you know, if they haven't yet, I mean, you consider, of course, getting serology, you know, for patients, especially if they haven't had vaccine. It's unclear whether vaccine causes serology to be positive, and I think it depends on which vaccine and that kind of thing. So, you know, if they have positive serology after the vaccine, well, I guess you don't know for sure. But if they haven't yet been vaccinated for whatever reason, you could consider doing that if you haven't already. And then, of course, if they have positive serology, at least they get that label. But, you know, I think what we're doing here in the province is what I've seen them doing elsewhere around the world, is that there was a period of time where there was limited access to testing, which was unfortunate. And so it's unfair to punish patients just because they could not be tested. And so validating symptoms and, you know, treating them as if in the same way that we would someone with long COVID is sort of what we're doing. But I see Dr. Arsenault has his hand up. Maybe he has a perspective on that.
Yes, let's unmute Dr. Arsenault.
Or no perspective, just another question.
Okay.
I lack perspective.
Oh, you have the answer.
No. So you and I see a lot of patients at the Complex Chronic Diseases Program who have shortness of breath as a complaint. The difference, and I haven't seen a lot of, I haven't actually not seen a lot, I haven't seen any post-COVID patients yet. So one of the questions that really helps me distinguish shortness of breath in patients with chronic fatigue syndrome is I ask them, you know, does it feel short of breath like you ran after a bus, or does it feel like you have difficulty getting a deep breath in? And about 95% of the patients who have shortness of breath as a symptom with chronic fatigue syndrome have the complaint is I can't get a deep breath in. And so I wonder if the patients with post-COVID who've had normal PFTs, normal blood gases, normal x-rays, if they describe their shortness of breath similar to patients with chronic fatigue syndrome or not. That's something I'm looking forward to figuring out.
Yeah, I think I think my sense is it's really variable, and people describe their symptoms very differently from patient to patient too. And for some people, it's very classic in that it's associated with exertion. And, you know, I don't know if I'm specifically asking them that question that you've been, so maybe I can't answer that, but some people tell me that they feel short of breath, or they feel like their lungs are burning, or they have a number of different descriptors, and it seems really idiosyncratic. So yeah.
Well, that's what I wonder too, because, you know, these patients, a lot of these post-COVID patients are going to have resolving lung issues and you know, some of them will have long-term lung issues, and kind of peeling those out. I wonder if that question actually will help us peel those patients out, because in the CCDP, I see patients who've, you know, it's clear that this is part of their chronic fatigue syndrome. They only have the symptom of shortness of breath when they're post-exertional malaise. They can run it, they could do these other things, but they end up getting huge investigations for something that I think we could just reassure them for.
Yeah.
Thank you for a great presentation.
Thank you.
Do we have any other questions? Okay, well, thank you, Dr. Jansen, for an excellent presentation. I'm sure it'll help us, those of us who are going to be going back to the clinics and seeing some patients. So just a reminder that we will be sending a post-event survey form to all the participants after the session. Please take the time to fill it out. We will read it. We will take your evaluations and comments to heart so that we can continue to improve. Project ECHO is a year-long program, and so there will be at least one of these sessions a month covering various aspects of long COVID to help us look after our patients. So every little bit of evaluation will help, whether you liked it, what you didn't like, etc. A final comment for attendance's sake, please put your name and your email in the chat box so we can get your certificate for accreditation out to you. And the next ECHO session will be held on Tuesday, August 10th, again from 12 to 1 p.m. Thank you.